Thank you very much. Thank you to Mihail, the organizers, for this really wonderful invitation. It's really a pleasure to be here. I visited the hospital yesterday and I was very impressed by the staff, by the fellows. Really a nice experience yesterday. Thank you. So, I'm here to talk about conduction system pacing. These are my disclosures. So we'll start with the case, a 7-year-old diabetic male with syncope. This is showing some 2-to-1 AV block. And this is his baseline echo. You can see that overall, although slow, his ejection fraction is quite preserved. Post-pacemaker implant, this was in 2018. You can see the apical lead placement here. And then a few years later, 3-4 years later, he developed heart failure, pulmonary edema, non-ischemic, so presumably pacing-mediated cardiomyopathy. This is his follow-up echo. So could we have prevented this? So I think the first question is, what is the chance of even developing pacing-induced cardiomyopathy? It's a very difficult question to answer. One reason is because we don't even have a sure definition of pacing-induced cardiomyopathy. When we look, all the studies are either retrospective or prospective in nature. The largest one here, 27,000, being retrospective, looking only at heart failure symptoms and not necessarily giving an ejection fraction definition. But let's say we call pacing-induced cardiomyopathy ejection fraction below 50%, then you're looking at about 16% possibility of pacing-induced cardiomyopathy, or if you're quite strict about it, at 40%, you're looking about 1 in 10 patients developing pacing-mediated cardiomyopathy over time. And when we look at, not just the frequency of pacing, but how does RV pacing actually create the dysynchrony? RV pacing dysynchrony is also similar to atrial fibrillation or tachy-mediated cardiomyopathy or PVC-mediated cardiomyopathy, where we have this irregularity, this dysynchrony that the heart just does not like. And so then, because of that, the heart will weaken. One way of looking at this dysynchrony is using ultra-high frequency ECG. It's quite a simple system where the regular electrodes, V1 to V8, are placed along the precordium, but we're looking at the activation at each one of these electrodes. And so, for example, if this is RV apical pacing, and V1 to V4 represent right ventricular activation, and V5 to V8 left ventricular activation, what you're seeing here is where we're pacing from the RV apex is a delay in both the RV and the LV. So both RV and LV walls are delayed, causing this dysynchrony. Let's look at other places around the heart where we put these leads. What about, so this is RV apex, we just saw that. What about RV inflow, which is essentially septum? So why don't we just put these leads on the septum? We know that septal versus apical pacing, at least in the early studies, did not show much difference at all in heart failure outcomes. And when you look at the dysynchrony that's created, it's still quite dysynchronous, both in the RV and in the LV, with this very wide kind of activation. When you look at the right ventricular outflow tract, although the RV is activated early, look how late and delayed your LV activation is. And so RV outflow tract pacing is probably even worse in these patients because we have such delay in the LV. What's interesting is when you actually perform His bundle pacing, you create this very nice synchronous activation. Why? Because we're activating the right and the left ventricles very synchronously. What's also interesting is that when we pace the RVOT or the septum, we think that we're doing a very good job because we're higher up on the septum, but that QRS is about the same, but look how different the dysynchrony is between the outflow tract and the inflow or the septum. So really, we're not really doing a good favor to the patients wherever we put these leads. Another way of looking at this is with computer modeling. I'm not going to spend too much time, but when you look at RV activation, or RV apical pacing, or biventricular pacing, we saw RV apical pacing where we're activating both the RV and the LV quite late. And so where red is early and late is green and blue. Biventricular pacing very similarly, where we're having early activation of the RV apex, but very early in the lateral wall, but somewhere in between, gives us a very desynchronous type of look. And finally, we can even exhibit this dysynchrony with strain on echo, where if this is selective His bundle pacing, so really the optimal type of conduction system pacing, look how clean, shortening or strain, we're seeing negative strain here. Whereas when we pace RV apical or even bi-V, we're having very, very desynchronous activation. So clearly, pacing the RV will create desynchronous activation, and perhaps with biventricular pacing we can improve things, but it's not the perfect solution. So where is the best place to put this lead to prevent that desynchrony? So in that 7-year-old male diabetic, this was right ventricular pacing, and then we can perform left bundle branch pacing where we implant that lead very deep into the septum, nearly reaching the end of that LV endocardium to reach the left bundle itself. So we have a very nice RSR prime activation here with a very nice axis where it's positive in 2 and negative in 3. Clearly, we're reaching the left bundle, the proximal left bundle branch here. So the original description of left bundle branch pacing actually was with the Netherlands group, where they implanted this lead very deep into the septum. They called it LV septal pacing, and the publication is in 2016, followed in 2017 by a few cases by Huang, and this is how we get to know left bundle branch pacing as it is today, where when we pace the RV here, and we continue screwing the lead deeper and deeper into the septum until we reach that left bundle, we arrive at a nice RSR prime pattern here in V1. When we look at the anatomical area where we're actually pacing, so if you look at, this is the right ventricle that's opened up from the right side, you can see here that this is the compact AV node. At the apex of this triangle of Koch, what we see is that His bundle recording, or that membranous septum, and then the septal tricuspid leaflet here. When we look at the other side of that left ventricular septum, so this is now the membranous septum that's highlighted here, we can see that it lies right underneath the aortic cusp, the right and the non-coronary cusps. And so below that membranous septum, or His bundle recording, is that proximal left bundle branch, which will then divide into 3 fascicles, the anterior, the posterior, and the middle fascicle in about 65% of patients. And so when we look at the echo, the forechamber, it almost looks as if that lead is perforating through, but we can never look at this apical forechamber. What we actually do is look at the short axis view, where we can see that the lead is actually not perforating through, but is very deep into the septum and clearly has reached the left bundle here. And in fact, the lead really, more and more what we're seeing is that that lead really has to reach that end septum to actually get the left bundle branch capture. But of course, the left bundle branch is highly variable in all patients. These are 3 separate patient autopsies of the interventricular septum. And here on the top is the right ventricle, the interventricular septum, and the bottom is our left bundle branch itself. You can see that this patient's left bundle branch is quite different than this patient's left bundle branch, which is very thick and clearly is going to be much more amenable to left bundle branch pacing than this patient here. Further, you can also see that there's quite significant scar that sometimes you have to pass through, or even arterioles that you may puncture on the way forward. So how many attempts at performing left bundle branch pacing we should be doing probably is a very good question. And in particularly, I don't know if everybody saw that recent case report in Heart Rhythm Society, the Heart Rhythm Journal this month, there was a case of a huge septal hematoma that caused dry tamponade, essentially expanding from the inside, that caused a patient death with one of the stylite-driven leads. So we have to be very careful about what we're doing when we're performing left bundle pacing. Now, certainly, everybody's left bundle is different. Also, the fascicles themselves, the arrangement, the anatomical differences are quite clear. And can be very highly variable. So wherever you're actually pacing, you're going to end up having a different ECG just by fact that you're pacing in a more proximal or distal location, or just based on the anatomical variations that you're seeing among patients. So let's look at how left bundle branch pacing is actually performed. If this is the RV septum on the left, and we have left bundle branch capture on the right, and this is V1, if we just look at V1 going through, so as we're pacing while we're screwing the lead, you can see that when we're capturing the RV septum, we have this ugly sort of left bundle branch notching, slurred type of QRS. As we proceed further into the deep septum, we lose that notching. And then further deep septum until we reach the LV septum, where we define that as an R prime. Although the definition of LV septal pacing is so variable, we still don't understand it completely. But we do know that there is an R prime in V1 now, but that's not sufficient. We have to continue screwing that lead further until we reach the left bundle itself. Not only do we have an R prime here, but we have a little bit of an isoelectric interval. We lose that pseudo delta wave that we saw with LV septal pacing. But it's a little bit more complex than that. But when we reach these different places, we're going to get different ECG morphologies based on where we're pacing. So left bundle branch pacing itself, where clearly this is a left bundle branch potential. The left bundle branch potential to surface QRS here is 30 milliseconds, so that's definition of a left bundle branch potential in this patient. When we pace, you can see the axis with left bundle branch pacing, but can be very different when we're pacing actually the fascicles, which commonly we do arrive at based on the different sheaths that we have and the morphologies of the right ventricles in the patients. So when we're pacing the left posterior fascicle, what we're seeing is a left anterior fascicular block. We're pacing the anterior fascicle, a left posterior fascicular block, as you see here. And when we're pacing the middle fascicle, we kind of get something in the middle, where we know that this is fascicular pacing because we have a fascicular pacing, fascicular potential here, here, and we develop, although it's not so clear here, but there is an S wave here in V6 that suggests that we are in the fascicle and on the proximal left bundle. So how do we know that we have attained left bundle branch capture? I'm not going to go through all the different criteria. That would be a little bit too dry, I think, for this, this session, but I will just make a few remarks on some of the ways that we can figure this out. So I do refer you to this Europace article, the Consensus Guidelines from 2023, that go through each of these steps on how to achieve true left bundle branch capture. But essentially, what we're looking at is left bundle branch area pacing, which would include left bundle branch pacing itself, where we're actually touching the true conduction system on the left. The left fascicles, where we're touching the left fascicles. But also left bundle branch area pacing may also include left ventricular septal pacing, where we're somewhere in the middle. Although more and more we're realizing that left ventricular septal pacing is probably not good enough, and we do have to reach that left bundle branch itself. These are the criteria. I'm not going to go through them, but it's a very nice way to go through the flow diagram as we're assuring that we are where we are. So the concept of transition is essential for determining whether we're in the left bundle branch itself. So this is essentially a transition that we see with unipolar decremental pacing, and it's really the gold standard for knowing where we are. So it doesn't matter whether you're just slightly touching the conduction system itself or you're completely directly on the conduction system, the left bundle. Either way, that would confirm that we are truly in the left bundle itself. So when we see non-selective to left ventricular septal pacing, what that means is that here in the red circle, we're at high unipolar output. That means we're only capturing from the tip. And we're capturing both the septum and the left bundle itself. As we come down on the output, so lower and lower, what we're seeing is that we lose the conduction system itself and are only capturing the conduction system, the septum. So what does that give us? Well, clearly the activation time to the lateral wall, if we're touching the conduction system, the left bundle, will be short, let's say, and will get longer when we lose that capture of the conduction system. So the R wave peak time, or LVAT, left ventricular activation time, will step out here, for example, 70 to 86 milliseconds, but essentially just meaning that we're losing capture of the conduction of the left bundle itself. And then there's non-selective to selective, which is actually, will probably make the point a little bit better. So if we're high output pacing, we're capturing the conduction system and the septum. As we come down on the output, now all of a sudden we're only capturing the conduction system. So what happens? We remain with the same activation time of the lateral wall, 70 here and 70 milliseconds, but what's very important is that you see this transition pattern occurring where now all of a sudden the R prime steps out. What is the R prime? The R prime is just activation of the right ventricle. So if we see the activation of the right ventricle step out, that means the R prime is stepping out. That means we are not caring about the right ventricle at all. We're only caring about the activation of the left ventricle. So that's why the R prime will be delayed. And that's a very important concept here that we use every day in the lab. And here's an example in real time, in real life, I should say, where you can see here the R wave peak time here, or left ventricular activation time, is 76 milliseconds. And then as we are coming down on the output, all of a sudden our R wave peak time is similar, but our QRS is now increased. It's only increased because now our R prime, our RV is quite delayed. And so clearly we have capture of the left bundle itself. There's certain numbers that we're associated with clear capture, where we, looking, what's the LVAT? People say, oh, is the LVAT 74 or 80 milliseconds? So this is important, except that there's many caveats to this, including if you're fascicular pacing, if you're very distal in the septum, clearly you're very close to the lateral wall, so of course that's going to be shorter. So a lot of little discrepancies here, but the pattern itself, that pattern difference, that transition is very important. And another very important part of understanding if we are capturing the left bundle itself is when we see a left bundle branch potential. We talked about it before. If we see a left bundle branch potential, and that potential to the peak of the V6 is within about 10 milliseconds of the pace beat to V6, then we know we're exactly where we are. And this is a very nice example of my colleague, Atul Verma, who did this the other day. So we see here, this is a left bundle branch EGM. You have a nice left bundle branch potential, and that left bundle branch potential to V6 is 63 milliseconds, and when we pace at that location, it's again 63 milliseconds, knowing that we're clearly on the left bundle itself, and this is a very nice example of physiologic understanding of the activation of the left bundle. And then finally, again, I'm not going through all the criteria, but current of injury is kind of the New York kid on the block, and it's a fantastic way to understand where we are with the tip of the lead. So this is current of injury, so COI. When we're in the RV, the current of injury, or the trauma that we're creating to the myocardium at that area is not so significant. As we go deeper into the tissue, you can see that that current of injury will rise, get much larger. Even when we get into the LV septum, even gets quite large. And as we reach the left bundle, we see that the current of injury will actually fall. And we can even monitor it. If we go too far, then we know that we've actually perforated into the left ventricle itself. And this is kind of the way that we set up. We have these cables that we're using with the non-stylet leads, or the 3830 leads, but Medtronic is going to be coming out with their own probably in the late summer. And another example here in real life, where the purple here at the bottom is our current of injury going from left to right, and you can see that the current of injury starts to drop around here. When we look at V1 in blue here, you can see that we are getting an R prime here. We continue to screw, and as the current of injury comes down, we know that we've reached the left bundle itself. And this is a nice example also of a perforation where this is V1 here going across, so we'll have a little bit of an R prime occurring. These are what we thought, capture beats. We thought, when we get these capture or template beats as we're going, maybe that's a good place to stop. It's not a good place to stop, actually, because you're still in the LV septum. You need to keep going. As you can see, the current of injury hasn't come down yet. As we move to the right side, we can see more, probably a transition coming here. And then if we screw too far, now we'll have loss of capture. So it can be very helpful to determine where we are and also to avoid perforation. So why not left bundle branch pacing in everyone? Well, it's not that easy to perform. If you want to perform LV septal pacing, it's not that bad. Here, in this really nice Spanish paper, Oscar Cano and his group looked at if you took a left bundle branch pacing strategy. So you tried to get the left bundle branch itself. So 71% of the time you were successful when you tried for left bundle. 24% of the time, or 28% of the time, you were not successful at all. When you just tried for left ventricular septal capture, actually a good 40% of the time you actually did reach the left bundle, but most of the time you just sat in the left ventricular septum. That's fine, but where it's really important is those heart failure or those CRT type candidates, where it really matters that you're in the left ventricular left bundle itself. So here, when we're performing left bundle for a CRT indication, 35% of the time you actually arrived at the left bundle itself. So it's actually perhaps not as easy to perform left bundle branch pacing in lower ejection fractions. And what's the data for CSP versus RV pacing? Really, there's no large RCT data for RV pacing versus conduction system pacing. The best we can actually get at is this, prospective study that compared RV versus HIS bundle pacing. It was very nicely done. It was from Pennsylvania, the Geisinger group versus a Danville Geisinger Medical Center, and they separately performed either HIS bundle pacing or RV pacing and followed the patients over time. There was about 50% ventricular pacing, and you could see that HIS bundle pacing did significantly better than RV pacing over time. And that was even true when you decreased, when you did a sensitivity analysis just looking at ventricular pacing at 20% or more. Again, there's more retrospective or even prospectively collected, but retrospective data, Milos Reloaded, of 3,600 patients looking at left bundle versus RV pacing. Clearly, there does look like there's benefit. But all these trials, unfortunately, have significant bias, which is why we're performing this study, left HF, left bundle pacing versus standard RV pacing, essentially for heart failure, looking at ejection fractions above 35% and randomizing them to RV pacing or left bundle pacing, performing an echo at baseline 1, 2, and 3 years, and looking at a maximum of 1,300 patients. The outcome is a hierarchical composite outcome of death, cardiovascular death, heart failure, and end-systolic volume index. And at 1,300 patients with the first interim analysis 750, we're here at 450 patients, and so we're doing quite well. And if you look at just the geography of Canada where we're being activated, this is kind of what Canada looks like and where all of our different sites are, so just for fun. There are many other studies that are looking at this. And I just want to spend the last 5 minutes talking about left bundle for CRT, because it's actually an interesting concept, and we're learning more and more as we go. So can we extend left bundle pacing to CRT indication? And I'm going to go back to the anatomy again. So this is the left-sided septum, the interventricular septum, where we see the proximal left bundle here and divides into the fascicles. So here you're looking at the left bundle branch itself, and it's just such a beautiful individual strands in this ribbon cable-like structure. They're all running in parallel. And that left bundle itself will then actually divide into primarily the left posterior fascicle, actually. And the left posterior fascicle will run and will activate the lateral basal wall, and then the anterior to the anterior aspect, anterolateral. And then these fascicles will then go into free-running tendons, and we call them false tendons that we frequently see on the echo. And they will activate the free wall, okay? So same thing on the right side, except the right bundle itself will come and only divide as it leaves the septum. So what I want to say by this is that this Purkinje fiber network, this HIS Purkinje fiber network, will guarantee the synchronous activation of working cardiomyocytes. So one activation, so it goes from, we transfer the conduction from the endocardium to the epicardium through the Purkinje system network here to the terminal Purkinje fibers. And then one of these Purkinje fibers will transfer the impulse to thousands of ventricular cardiomyocytes through these intercalated discs. And so the activation is really from the endocardium to the epicardium, from the apex to the base. So that activation can be preserved if we can somehow use the HIS Purkinje system. So it's a very good target for CRT potentially. And one other thing we need to note is that when we look at left bundle branch block itself, it's not, when we call left bundle branch block, it's not a problem or a diffuse disease of the left bundle itself. It's in fact a discrete disease. So it's almost a misnomer that left bundle branch block perhaps should be called intrahissian block or something much more proximal, because it truly is a true block. So the original concept of left bundle branch block was that there was some disease or something that was approximately some type of block in the septum, and then that block caused further delay of activation further and further down you went. So that was the original theory. The more modern theory is that there's a complete conduction block in the left-sided HIS, so that intrahissian type block, And that will allow then a problem for the rest of the His-Purkinje system. So what I'm trying to say here is that we could potentially bypass this conduction block with left bundle branch pacing, or even His bundle pacing, depending on where that block is. And we can perform a left-sided EP study, where you can see here, this is a duodecapolar catheter that's sitting in the LV apex and lying along the LV septum. And so when we look at a normal activation of the His-Purkinje system, so a very normal narrow QRS here on the surface ECG, what we're seeing is AHV, so atrium, and then His is activated. We have the Purkinjes that are activated prior to the activation of the ventricle from the apex to the base. That's normal, so apical to basal activation of the LV. When we get left bundle branch block, what we're seeing is a disruption in the His, so this is intrahissian block, essentially, where the activation of the ventricle is very disarrayed, desynchronous. There's no clear way of activation here. Whereas intraventricular conduction delay, which is really a problem with the muscle, you can see it very nicely here. This is not a disruption of the His bundle system at all. It's in fact a problem with the muscle. We just get delay in the entire system, where the activation between the apex and the base is the same as with normal activation. And when we have a baseline left bundle branch block here, and when we pace at high output the His bundle, we can actually recruit those Purkinje potentials here and recreate that normal activation of the ventricle from apex to base. So in this patient who has baseline left bundle branch block, if you pace the His and recruit the Purkinje fibers, we can actually bring back a normal conduction for this patient. So in this patient, clearly left bundle branch pacing would be a good idea. But it's not in every patient that is a good idea. So in patients who have left intrahissian block or proximal left bundle, then sure, left bundle branch pacing might be very good. But in those with IVCD or a mixed bag picture, clearly left bundle branch pacing will not be the proper way forward for cardiac resynchronization. And just in the last slides, showing that everybody talked about this data, retrospective CRT population, left bundle branch pacing versus biventricular pacing, showing significantly improved outcomes with CRT with left bundle branch pacing as compared to CRT or BiV. But this represents major selection bias, and the more and more I understand and go through my career, I realize observational studies are just that. There's significant bias there and really need to be shown in randomized controlled trials, and that's why really a testament to Mihail and Ken Ellenbogen doing this left versus left study, randomized trial that is looking at exactly that, left bundle versus biventricular pacing in these CRT populations. So we should really definitely recruit anybody who has a CRT indication should be recruited for this study so that we have a definitive answer. So that's my conclusion, just for sake of time. Thank you very much. It's really an honor to be here and present to you today. Thank you.